Lina, this session is yours.
You, Fitri Adil, our great master of ceremony in day one and day two as well. Well, good morning, distinguished guests, respected speakers, and all participants joining us in this big event. Welcome back today to our second Rumah Sakit Husada International Conference on Global Health Issues for Society 5.0. I am Linauli Happy Christina Zega, and it is my great honor to greet you back, to serve you back as the moderator for today's session. On behalf of the organizing committee, I would like to express our sincere appreciation to all participants who have actively engaged in yesterday's session and continued meaningful discussion on global health transformation in the era of Society 5.0. Today, we will continue exploring innovative perspective, research findings, and health strategies that address the complex challenges of modern healthcare systems, particularly how on digital transformation and human-centered technology can improve the quality of life and public health outcomes. Now allow me to introduce our distinguished speakers for this Day 2 Second International Conference. Our first speaker is Dr. Nur Azliana Azizan, a senior lecturer and coordinator of Health and Wellness Research Nexus UITM, Reno. Then we have Professor Michael Joseph S. Dino, PhD, MAN, LPT, FWN, FFN, MRCSI, and EP, a postdoctoral researcher scholar who will share valuable perspective for us today. Next, we have Ibu Dr. Eni Juliani MK, a nursing educator and academic leader from Sekolah Tinggi Ilmu Kesehatan RSUSADA Jakarta, Indonesia. And last but certainly not the least, Ibu Dr. Dia S. Saminarsi, as a founder and CEO, Center for Indonesia Strategic Development Initiatives, or CISTI. Each of them will have around 30 minutes to present, and afterward, we'll have a Q&A session plus documentation in 10 minutes. Well, ladies and gentlemen, distinguished guests and fellow participants, it is a great honor for me to introduce our distinguished speaker for today's in this session 1, Dr. Nur Azliana Azizan, who will talk about geriatric health in the era of global aging, challenges and transformation in physiotherapy. But first thing first, let me show you our first speaker's CV. Ibu Dr. Nur Azliana Azizan, a senior lecturer at the Center of Physiotherapy, Faculty of Health Sciences, University Technology Mara, or UITM, Malaysia. Dr. Azliana holds a Doctor of Philosophy or PhD and a Bachelor of Science Physiotherapy from University Technology Mara. She currently serves as the coordinator of health and wellness at the Research Nexus, or RENEW, and has also acted as Deputy Director of the same institution. Her areas of expertise include geriatric rehabilitation, exercise prescription, therapeutic exercise, and aging and mental health. With extensive teaching and research experience, she has supervised numerous postgraduate and undergraduate students and has published over 30 research papers in leading international journals. Dr. Azliana has accumulated research grants exceeding Ringgit Malaysia 1.4 million and has been recognized with multiple innovation and academic awards, including gold, silver, and diamond medals, for her outstanding contributions to physiotherapy and healthy aging research, of course. Beyond academia, she has served as a visiting lecturer at university in Indonesia, Japan, and the United States, and has collaborated widely with international institutions such as Tokyo University of Technology and the University of Wisconsin-Madison. She also serves as the leader of the Geriatric Specialist Interest Group, in the Malaysian Physiotherapy Association. Dr. Asian's scholarly contributions and leadership in geriatric physiotherapy have greatly advanced the field of aging and rehabilitation science in the region. Ladies and gentlemen, please join me in welcoming Dr. Nur Azliana Azizan. Please give warm applause.
Right. Everyone listen to me?
Yes, we can listen to you.
Alright. Okay. Good morning, everyone. Thank you, moderator, for very warm welcome and introduction of me. I'm Azlana Azizan. You can call me Dr. Yana. So for today's sessions, I would like to first and foremost, I would like to thank to the organizer for this the second international conference Sekolah Tinggi Ilmu Kesihatan Rumah Sakit Husada. Welcome everyone. So without further ado, let me share my slide. Okay. All right. Is it on the screen now?
Yes, it is on the screen, Doctor.
All right. So for today's sessions and topic regarding the geriatric health in the era of global aging. Okay, let's go to our table of content. This is very quick one. I will start with the introduction and the purpose of physiotherapy and the global aging, followed by the global demographic shift and the regional aging trend, and what the health system impact and force challenges and also the core challenges in geriatric physiotherapy perspective, and a little bit about the assessment of frailty, cognition, and functions, and what the exercise prescription for falls preventions, model of care and technology integration, and the future priorities and clinical call to actions. All right. Next, for the first one, a little bit introduction. Okay, we know that the world is aging faster than ever. In 2020, people aged 60. Here in Malaysia, the cutoff point is 60 years old. But in overseas, the cutoff point is 65. All right. So by 2020, the people aged 60 and all the numbers, they outnumbers the children under 5 for the first time. And it is expected by 2030, 1 in 6 people worldwide will be over by 60. By 2050, this group will double to 2.1 billion, with 80% living in low and middle income countries. So we need to set the goal to extend the ability, purpose, and the independence through physiotherapy perspective, which we would know that this common health issue in older adults include hearing loss, vision problems, chronic pain, osteoarthritis, diabetes, depression, and also dementia. So all this, we call it geriatric syndrome. So most aging differences come from the social and environmental factor, not genetics. Housing, income, education, and community design shape the health outcome. So here in the concept of healthy aging itself, it depends on the physical activity, a good balanced diet, tobacco avoidance, and safe, inclusive environment that support the independence. So the UN Decade of Healthy Aging target the 4 goals for healthy aging purpose. We need to reduce the ageism, build age-friendly communities, deliver integrated care, and ensure access to quality long-term support. All right. To staying mobile or independent in older adult is so important for older adult. Why so important? We can group into this. We mapping into the exercise or generally will improve the moods, confidence, and energy among them. To reduce activity that leads to stiffness, weakness, or loss of independence. And regular movement or exercise is important so that they can preserve the strength, flexibility, and coordination for older adult. As long and also activity will reduce the risk of fall and help control chronic diseases. Okay, so how physiotherapy need to support this healthy aging? As we know that physiotherapy work in multidisciplinary, it tackles about the pain management, balance and falls preventions. Physiotherapy also provide to maintain mobility and independence among this group by improving strength and flexibility, and we need to customize program for every individual or the adult. So this is what we call the screenshot of my previous paper last year regarding the bibliometric map on the co-occurrence of the geriatric rehabilitation in Scopus database. So we can see that this trending, the future trend regarding focus on the geriatric trauma, fragility fracture, focus on the knee and also sarcopenia and frailty issue. So here we know that by this current trend, geriatric physiotherapy need to focus on this element, sarcopenia and frailty among older adults. All right, you can go and search for this article to read further. All right, next. So as a recap, yes, physiotherapy roles in early rehab will be shorten the hospital stays for older people, and we need to integrate both function and environmental factor to and we need to promote mobility, independent mobility, and to reduce the mortality rate by treating the frailty, falls, and chronic diseases through emphasis on engagement in exercise itself. Okay. So here's a series of examples of the previous research regarding the global, region, and national burden disease. This paper concludes that mobility limitations are widespread after the age of 70 and drive disability burden and loss of independence. Here it comes why physiotherapy should focus in this group to reduce the burden and loss of independence rate. The second paper talk about the effects of multi-component exercise. When we call it multi-component, it integrate the component of strength training, flexibility, endurance or aerobic, and also balance and agility also, flexibility also. This is what we call is multi-component that improve the frailty in post-COVID-19 or the adult after intensive care unit. This is a single group retrospective study. So this paper summarized about the exercise-based physiotherapy that improve the IADL or activity of daily living in the frail older adult. So the effect is clinically meaningful across the multi-component program. So we need to focus on the multi-component program when we prescribing exercise for older adult. We cannot tackle only one what we call one training or one program. For example, strength training for lower limb, just to tackle for those with the frailty. No, we need to integrate the multi-component exercise program. And then this paper, the next paper regarding the early ambulation and the length of stays of older adults in hospital for acute illness. So physiotherapy play a role in this global aging by educate or by what we call physiotherapy limb by early mobility during hospitalization shortens delay by about 1 to 2 days on average in protocol with daily ambulations. So we cannot let go the roles of physiotherapy by chest physio and limb physio, and we need to educate these young physiotherapists nowadays to start early ambulation as early as they can after post-operative or during the hospitality stage. Okay. Next, we go to the global demographic shift and regional aging trend. As you can see in this graph, all right, the global share people age 65 plus rose under, as I mentioned before, as keep increasing, up in about 10% in 2020, and it's projected to reach 60% by 2050 and 25% by 2100 in the years, and 1 to 4 people worldwide will be over 65 years by the end of this century. So you can see the trend is moving upwards, all right, for all the countries in global trends, and this aging will affect this region. And we need to know that Europe and the East Asia are the fastest as compared to Africa. Right? And countries like Albania and China, we have more than 40% of their population age 65 years old. These African nations will remain the youngest, with the populations under 50% people aged 65 plus. So physiotherapy can see this exponential demands growth as older adults become a quarter of our global population itself. So we need to use our care model whereby we need to shift from episodic rehabilitation. For example, episodic mean that we need to treat patients based on their symptoms. We need to focus for the long-term functional maintenance to tackle the healthy aging purpose. All right. The next graph regarding the regional distribution of older adult and also the aging by development. Europe and Asia will hold most of the global 65 plus population by 2050, and Europe remain the oldest region. But we need to know Malaysia and Indonesia also drive the largest increase due to our population size. In Malaysia, it's expected by 2030 will be the aged country, another 5 years more. All right, are you ready for that? So as physiotherapy, we need to educate our resource allocations must expand faster in the Asia and Latin America. Here, as compared to what we call the most developed region, less developed regions, we can say that more developed regions show the steepest rise in 65 age from 8% nearly up to 30% by 2050. So less developed region, the rise about less than that, 3% about to 13%. And less developed country grows slowly but steadily, still double the numbers in the same period. Okay. Here also we can say that what the physiotherapy rule, we need to focus on the both technology model and and focus on low income country. Okay, next we move to our third issue regarding the health system impact and the workplace challenges. Here, we can divide it into the workplace and capacity. We can say that demand for long-term and long-term care grow more faster. And then low pay and status make the staff retention become hard, and about 1/3 of the doctors and 1/4 of the nurses are over 55. So this focus on the rural and poor area to face the biggest shortage. Right, in terms of clinical complexity, over the half of the adult age 60 plus have two or more chronic conditions, or the what we call CVDs, cardiovascular diseases, and also this rehabilitation needs rise in the age and disability. The main cause of this may include the hearing loss, arthritis, and also the back pain. And in terms of cost and service use, this aging and chronic diseases will drive the higher cost. Yes, for sure, regarding the hospitality stays or the medication bills, all right, result from the falls, heart failure, are also even the adverse effect from the polypharmacy itself. All right. In terms of system response, the move care to community and primary setting use a small multidisciplinary team, and this group run a very what we call very small strength and balance program that use a remote follow-up to keep the patient active and track the gait speed, function, and falls outcome. This is our challenges in every community dwelling older adult regarding the institution also. Next, we move to number 4 regarding core challenges in geriatric physiotherapy. All right, in aging itself, we call it as these 5 core challenges. First, as I mentioned before, the issue regarding frailty and sarcopenia. All right, and we will go in depth for each of these later on. And number 2 regarding falls and balance disorder among this group, and cognitive impairments such as dementia, regarding multimorbidity and polypharmacy, and access to equity gaps. So this is 5 challenges in geriatric physiotherapy practice that I believe include Malaysia and Indonesia also facing the same problem. Right. So regarding the issue number 1, frailty and sarcopenia. So what this is, okay, is a loss of muscle strength and functions that raise risk of disability and death. Okay, sarcopenia reduce in muscle mass, sarcopenia. Reduce in muscle strength, we call it geniopenia. All right, both of this is a negative outcome that will lead to frailty. So as physiotherapy, we need to early detection. We need to use several outcome measures, for example, gait speed, chair stance, and also grip strength to measure whether this group of population having a pre-frailty or pre-sarcopenia before we can treat them accordingly. So studies shows that this sarcopenia and frailty should treated with the progressive resistance training at least 2 to 3 days per week, all right? Plus, educate protein intake nearly about 1 to 1.2 gram per kilogram per day. And then this is a special case adjusted for those with the kidney diseases. And we need to add power tasks like rapid sit to stand. Why sit to stand? Because sit to stand, what we call, it mimics to the functional activity. So older adults usually sit and stand, walking around and turning. This is what we call the functional activity. So sit to stand test, we need to focus on this because it's mid to functional activity, right? And then the SPPB is another outcome measure and their grip strength monthly, all right? So here you can Google this paper, go and search their algorithm and learn how to perform all these practical outcome measures. All right. So number 2, we move to the falls and balance disorder. So which shows that studies inform that about 1 in 3 people, older adult, falls each year. So fall is a major issue, regardless whether this older adult sitting in the community or institutional, ataupun we call it rumah seri kenangan here in Malaysia. Okay, so exercise that challenge balance will reduce the fall rate by 21 to 34%, correct? Majority, previous studies and research, they use the Otago principle, Otago program, include the Tai Chi component and also multi-component strength, plus with the balance program. So they believe that the exercise prescription should have at least 3 hours per week, right? This component to tackle the reduce in the risk of falling in older adult. So they screen with the TUG, or we call it time up and go test, another performing outcome measure, and also 4-stage balance, right? They also advise to add on the home safety, footwear, vision check, and then medication review. As we know that all these are external factor that leads to falls in older adult. All right. So you need to identify first what the internal or external falls in older adult, and then we can tackle and review that issue by monthly lah. All right. Next, we move to the third issues regarding the cognitive impairment. So prevalence shows that for this paper, it shows that mild cognitive impairment will affect roughly about 20 to 24% of older adults depending on the setting, whether the community or institutional. And studies shows that those living in institutional have a more depressed or characteristic of mild cognitive impairment as compared to those living in community like in kampong, we know, right? And then aerobic and resistance exercise also will improve the mobility and may support the cognitive functions to build activity into weekly program that use simple cues. So aerobic and strength training shows a good significant effect to improve the mobility, thus improve the cognitive function simultaneously. All right. And you need to also integrate with the dual task balance work with the safe supervision. What you mean by dual task balance? For example, when we ask the patient to perform time up and go test, TUG, all right? ask patient to calculate or multiply, or for example, multiply by 2, 2, 4, 6, and then you progress into more challenging part. For example, you ask the patient to calculate from 100 to maybe 100 to 90, 100 to 80, counting backwards, something like that, more challenging, right? And then screen with the mini MOCA. This is what we call a questionnaire for those with the mild cognitive impairment, whether we need to know whether they have dementia, or sometimes we can use the depression, for example, what you call G15, geriatric depression, GDS 15, to check whether this older adult having depression or not. So it is another part of cognitive impairment that we need to focus to set our functional goal, like faster the TUG or better the gait speed. Okay. We move to another morbidity, and also polypharmacy. So we do believe that more than half of the older adults having 2 or more chronic conditions. For example, diabetic, hypertension, cardiovascular issue. All this is a common in older adult. But with this come another issue, what we call polypharmacy among them. It's often categorized by 5 or more medicines taken together. They will adverse the health benefit for the older adult, and they will increase the risk of fall. Why? Because this medication also sometimes they have a drug effect, such as dizziness, what we call mengantuk, and then loss of balance. All this will be a lot of confusion and will increase the risk of hospitalization among them. So we need to coordinate with the primary care and also pharmacy for describing these medications, and align with the exercise dose with the disease burden, and monitor the orthostatic blood pressure, and use the shared care plans. We need to focus on the multidisciplinary also when we prescribing the exercise for individualized older adult. Okay. Okay, let's move to another last one, core challenges regarding the access and equity gaps. From this paper, we shows that the problem here now regarding the rural residents. So rural residents with the low income and low literacy, with the language barrier, will limit the access to rehab. Okay, so this we need to offer a community program or home-based plan or physiotherapy lead focus on the tele-rehabilitation, which is safe and non-inferior to in-person care for many conditions. All right. So we need to build an age-friendly, integrated services across primary care and community partners. This will track the outcome by demographic to the close gap. Every of our country and our state will focus to provide a more age-friendly community program. Okay. Here, let me touch a bit about physical performance. Usually, this is the 5 basic, what we call the high reliability and validity, and it's a cost-effective for older adult. For example, SPPB. Later, you can go and find what is SPPB, and you go look into the YouTube or into the what we call TikTok. Also have about SPPB. What is SPPB? It's the combined balance, gait, and speed, and chest and test to provide the overall score of the functional function. So SPB is another performance outcome measures. It's good for all the people. Same goes to TUG to measure the time to stand from a chair, walk 3 meters, turn back and sit down. So time taken if the patient having complete the test. So TUG also can be progressed from the basic TUG to the more advanced, whether it's a dual task or cognitive task, right? And here we have a 30-second chair rest test. It's another test for to assess the lower limb functions and strength regarding how many times that people, older adult, can stand up and sit down in within 30 seconds. All right. And we do have gait speed. It to measure the walking speeds over the short distance, and also the grip strength. Why the grip strength? To measure the hand and the forearm strength using the hand dynamometer or JAMA dynamometer. So these all 5 physical performance, we need to perform at least once monthly to measure the progress of our older people and to know whether they have the tendency to having frailty or pre-sarcopenia among this group. Okay. In terms of frailty also and cognitive function here, frailty also we have another what we call special tools. Okay, this is what more into the questionnaire base, right? Minicoc and also mocha for those with the cognitive function. This is another questionnaire also. Okay, so frailty you can download. You can have frailty tools in your handphone also. Okay, so this we call CFS is a 9-point tools that used by clinicians to assess the older people living of frailty. Okay, the higher score will indicate greater frailty. Okay, higher, greater. Okay, and then this score is assigned based on the clinical evaluation of the person's functional status, mobility, and activity level. Okay, everyone, you can download these frailty tools in your app and try to answer by yourself, and then having trial to your patients. Okay. Here, this is example of 9 scale point in the CSF. Okay, clinical frailty scale. Previously, they have about 7-point scale, and then they improve into 9-point scale. Okay, start with the very fit, well, managing well, vulnerable, middle frail, moderate frail, severe, very severe, and terminal ill. Okay, for example, for outpatient in your rumah sakit or in your hospital setting, usually they can come as an outpatient. Usually we have about managing well or vulnerable this stage, whether 3 or 4 cut off point out of 9. So this is here physiotherapy to tackle in the rumah sakit. Otherwise, sometimes in the what we call in the hospital in this hospital setting ward, they have also mild to moderate frailty or even severe frail, like the vegetative state. Okay. Those with the wheelchair bound, clear cut, they have a severe frail. Right. You can use this questionnaire to categorize your patients or your older people. Okay, next. This is example of mini cognitive test. Mini-cog is a brief test for cognitive impairment. You can download from this website and try to answer by yourself and then ask the patient to try to answer this score, right? So whether the people, for example, the step 1 regarding the 3-word registration, we need to ask the older people, look directly the person and please listen carefully. This is the clear instruction. They have got 1 to 6 version. You can choose any of the version. For example, banana, sunrise, chair. Okay, ask the patient to recall and remember and spontaneously recall without any cues lah. So kita ask the patient to memorize these 3 words. Okay, banana, sunrise, and chair. And then the step number 2, clock drawing. Kita ask the patient to draw the clock. For example, draw the clock for me. Put in all numbers where they go, and when it's complete now, set hands to 10 past 11. Betul-betul tak dia buat untuk jam yang menunjukkan pukul 10 melepasi jarum 11. Alright, this is example. And then step number 3, kita ask patient to recall balik what the term or the word we give previously. For example, banana, sunrise, chair, whether they can replicate balik betul ke tidak. So we put the scoring here. So the total score should be now score 1 if they can answer correctly. 0 to 2 regarding the normal clock or not, and 0 to 5 regarding the recall. Okay. Next, regarding the MOCA, this is example of questionnaire. You can download in this website also. This MOCA, what we call it Montreal Cognitive Assessment, is a rapid screening instrument to know whether these people or this group having a mild cognitive dysfunction. So you can choose either one, whether want to use mini-cog or MOCA. All right, to assess a very different cognitive domains such as the attention and concentration, the executive functions, memory, language, visual constructional skill, conceptual thinking, calculation, and also orientation. So, and but in Malaysia, for those who want to use this MOCA, you need to have license for that, right? Not everyone physiotherapy can simply apply this, but you need to go and take your cert lah to try to run this MOCA for patient. Okay. Next, we move to the exercise prescription and falls preventions. As we know that, yes, exercise must have include multi-component. Why multi-component? The strength training or resistance, we need to train at least 2 to 3 days per week. We need to aim about 1 to 3 sets over the 6 to 12 repetitions. Okay. Sometimes we need to use the 1 RM or 10 RM regarding to the percentage that you want to focus. And you need to have a rest about 1 to 2 minutes between the set. Why 1 to 2 minutes? Because you want to avoid any injury, or we want to avoid fatigue. You need to remember this is your older people, so fatigue issue is become common. So you need to take about 1 to 2 minutes between the sets, right? And focus on the major muscle group. They include the hip, the knees, and also the shoulder. So progress loading when 12 repetition become so easy for this group. So you need to progress. Regarding the power itself, yes, same goes to the strength. How about the balance? Okay, balance usually we practice every day. Most days include the narrow base stance, tandem stance, the leg stance, stepping, and dual task drill. Right? Usually we need to perform daily at least 3 hours per week of balance challenging exercise to reduce the falls, to reduce the risk of the fall for these older people. Okay, how about the endurance, flexibility, and also the bone health? Endurance, the studies shows that SSM, SMs regarding SSM, they believe that accumulation of 150 up to 300 minutes per week. We call it moderate intensity. Okay, the intensity would be moderate intensity, or 75 to 150 minutes vigorous, or equivalent to the max. Use the talk test. What is talk test? Talk test usually macam we ask the people, the older adult, to keep talking with us. For example, if the patient can sing a song, usually it's a low intensity for them, right? But if you ask the patient, dah makan ke belum? And then these people say, sudah makan. The sentence quite short, it quite be moderate intensity. But for those yang macam what we call, you ask patient, dah makan ke belum? And then patient say, nah, yes or no. Only one sentence. So these indicate about high intensity for or vigorous intensity for them. So this is what we call the talk test. Okay, it's very simple test that you can ask patient during the test. Okay. And then regarding flexibility and mobility, you need to train large joint 2 to 3 days per week after warming up or cooling down sessions, and core stretch about 20 to 30 seconds up to 2 to 4 repetitions per joint. So you need to pair with the ankle, hips, and thoracic spine. Okay, regarding the bone health also, we need to include the weight-bearing component that give impact with the tolerance. Okay, you need to progressively resistant for hip and spine, combined with the balance and lower fracture risk. Okay, this evident to support the physical activity and osteoporosis prevention among this group. Okay, regarding protein intake also, yes, as I mentioned before in the previous slide, you need to you need to advise the patient to take at least 1 to 1.2 gram per kilogram body weight per day. So distribute protein across the meal. They include lysine-rich sources such as dairy, eggs, soy, fish, and legumes. So these will, with the high training load, we need consider the upper end with the renal status in mind. Okay, usually patient when they perform a very good exercise program, but they forgot about the protein intake, later you can see the trend progressively akan decline also. Therefore, you need to advise patient focus on their meal also, and focus on their exercise component together as a multidisciplinary, as a simultaneously, so that they can gain the benefit of exercise itself. All right. In terms of safety screening and also how to coach on track, you need to make sure and advise patient at least to screen for risk and medication that the risk, check the resting blood pressure and osmotic change during the sudden up, and also start to lower and progress your weekly. Stop and evaluate if the chest is pain or you have a SOB, so better stop. So this is the what we call the do and the don'ts that you need to educate for your patient first and foremost before you start prescribing exercise for them. And then how to coach and track this group. Usually we set our strength, our goal, mobility per month. You track dia punya outcome measures such as SPPB, the gait and the balance, or 30-second chair rest test. You can either use this one, or you can use the gait speed every 4 to 8 weeks. Okay. Execute the balance practice
Kirain mau jalan tapi lagi jalan.
at home. All right, never mind. It's okay. So that I'm not lonely, right? Okay, let's move to number 7. We need to look into the model of care and technology integration. So here, the current issues, the current trend, we focus on tele-rehabilitation and community care. So use tele-rehabilitations to extend and to outreach your people, your sample, your subject, okay? By using those who have faced problem with the transportation or mobility barrier. So we call it physiotherapy lead. Exercise-based tele-rehabilitation that improve the functions and quality of life as comparable to those in the in-person care. All right. So we need to deliver a balance and strength program at home using our what we call home equipment. Okay, committee and home-based multifactorial interventions may reduce the fall injuries in older people, and we need to build a simple technological workflow. Example, video visit. You give a remote exercise supervision to monitor, and then by phone follow up, or just to improve their adherence and continuity to engage in your prescribing exercise, okay, for tele-rehabilitation. Or sometimes we can use a logbook that you can submit using the short Google form, just submit. But those with the tele-rehabilitation, remember, with the low literacy or with the low internet coverage, sometimes it give you barriers lah to deliver this tele-rehabilitation. Okay, so you can track the outcome within 4 to 8 weeks of cycle. Sometimes you want to use the same outcome measure. For example, if you use TUG for the baseline, then you can progress to track the outcome for the 4 and 8 weeks using the same TUG. Whether they improve in time to complete, they are more faster and they're safe to complete the test within the time given. So you need to remember less than for generally for male and female, usually less than 11 seconds should be okay. Low risk for falls in older adult. Okay. Next, in terms of multidisciplinary collaboration, physiotherapy cannot work alone. All right, we need to use to CGA. CGA is a comprehensive geriatric assessment. This CGA will coordinate the care across the medicine, nursing, physio, pharmacy, and also social care. This CGA will reduce in mortality rate, okay, kadar kematian, and also readmissions compared to usual care. So usual care meaning that kalau you focus on physiotherapy also just physiotherapy alone. Okay, you not multidisciplinary collaboration. And you need to embedded caregiver support. The role of caregiver very, very important for these aging populations. And you need to standardize the weekly team handles, share one problem list, one functional goal, one medication action, and one safety action for each of the patient, remember? And then evidence supports to coordinate person-centered planning with CGA model. So this multidisciplinary, sometimes when we have an issue, we do our home visit also in Malaysia. hospital setting, sometimes we don't want to discharge the patient. We do visit their home first to remove all the hazard, and then to make sure the house is safe enough to eliminate all the external factors that lead to falls. Okay, we do home visit. And then in terms of third model regarding a primary care interrogation, yes, regarding the sarcopenia and frailty, previous one, we need to screen for decline in intrinsic capacity. Okay, intrinsic capacity, such as frailty and sarcopenia issue in primary care. Then we create a personalized care plan. Follow the WHO ICOP. Everyone, please go and look about what is WHO ICOP. We need to use this as our step for identifications, assessment, and community referral. This is what we call the global standard now. The primary care integration use this one just to tackle the current issue facing by older people. Okay, you need to apply opportunist case finding for fall risk in primary care and refer to high risk adult for comprehensive assessment and exercise. So we need to develop a hospital at home pathway with the primary care oversight when appropriate, and hospital at home can lower readmission and long-term care placement by reduce the mortality after early discharge. You need to remember sometimes when they have a negative cycle among these older people, when they start to fall, they refer to hospitals, and then they stay in the hospital for long-term care, for a very long-term in length, and then they're discharged, they're having a declining in the lower limb strength, and then another incidence of falls happens again, and this negative outcome will go and go continually. All right, so we need to at least try to hospital at home to try to lower the readmissions to the hospital setting. Okay, last but not least, regarding the future priorities and the clinical call to actions, we do believe that strengthened preventive physiotherapy is so important. We need to shift our focus by treating the disability. For example, patient come to you with a back pain or neck pain or knee pain. You cannot treat as it is regarding knee OA also. You need to prevent how these older people will having another second episode of diseases. All right, preventing it. We need to prevent another issues or another geriatric syndrome, what we call, and begin functional screening at the age of as early as 60 using a simple tool such as gait speed or SPBB, right? And build a falls prevention and strength program into community center and primary clinic. Even in your setting, in your hospital setting, you can have a falls clinic. Okay, just create another what we call living lab or falls clinic, just to tackle the risk for these older people. Whether patient tu datang, pasien datang, kita buat assessment so that they know whether they have a low risk or high risk for falls in the future. So you have a falls clinic, very not a large space, just a small space, just for falls clinic. You can screen using the standard gait speed, SPBB, TUG, or even 30-second chair rest test. Okay? And then you need to expand the access and equity, bring the physiotherapy to rural, low income, and homebound adults through mobile or tele-rehab program. Try. If you cannot do bi-weekly, try to by monthly. Okay? Try. And then integrate the interdisciplinary care, the link physiotherapy with the nutritionist. Nutritionist is so important. Nutritionist, and also pharmacy, regarding the polypharmacy, previous one, and cognitive health services. So you need to integrate with all these health professionals just to share your plans and to join reviews to reduce the hospital readmission. This is the key point here. And then you can nowadays we have all the artificial intelligence of the machine learning. We come the digital health tools. You need to use something that related to wearable sensor, just to telemonitoring to track the progress and adherence. Or sometimes you use the wearable sensor to detect whether this patient having falls or not. Okay. Here we have some came the idea with the innovation part. We can have a sensor, non-sensors or sensors regarding the falls prevention, and also to track the adherence in exercise for home-based exercise. And in terms of policy and education reform, yes, please include the aging and mobility preservation in national health plan, partner with the universities as we go now, good, to expand our geriatric specialization track. Okay, so I conclude healthy aging is not about the expanding the life alone, it's about extending the ability, purpose, and independence. So physiotherapy stands at the center of these missions. So with that, I'm thank you.
Well, thank you, Dr. Riana. This is such an extraordinary celebration, wonderful celebration, Dr. Riana. I'm sure most of the participants want to discuss a lot of things with you. So that's why
Okay.
we are open
Sure.
to the session of question and answer. If there is anyone who wants to deliver your questions, you may raise your hand. Yes, I have the first question from Physiotherapy Sabrina. Yes, Sabrina, please deliver your question.
Good morning, Dr. Adriana.
Morning, Sabrina.
Thank
How are
you for the
you?
opportunity. I'm good, thank you. Thank you for the opportunity. The presentation was outstanding. I would
I
like
think you.
to introduce myself first. My name is Sabrina, and I am from the physiotherapy study program grade 3. And I would like to ask a question is, what extent can technology such as walking aids or wearable sensors enhance independence among elderly? Thank you.
All right. So I can may I repeat your question, Sabrina? To what extent these technologies, such as sensor or working aids,
Yes.
okay, to reduce the falls. Betul ya, Sabrina?
Yeah, betul.
Okay, to what extent? Okay, I managed to publish several papers regarding this wearable sensor. They have two wearable non-sensors and sensors, but nowadays sensors should be what we call dibawa ke hadapan lagi regarding false issue. And then dia ada juga what we call the sensor that detect they have a 3D cameras just to put in the bedroom, and then they can monitor the what we call the progression of the balance component, the what we call the proprioceptions, and also the what we call in engineering part, they have monitoring the motions itself to predict whether this patient having falls or not fall. But they have also detector for sensor just to give the alarm for all the people after the falls. So to what extent actually these technologies can prevent in terms of prevent for fallings, and during the falling we give the alarm ataupun give the call to the ambulance or call to the caregivers, and post after recovery also these technologies can help in terms of improving all the functional independence that focus on the low limb. Is it answer your question, Sabrina?
Yes, thank you, Doctor.
Lepas ni buat lagi banyak inovasi regarding the sensors, such to detect whatever might be the gait of the or the people itself, whether they have a what we call dropping scissoring gait, we have a drop foot, what kind of gait you need to compare with the normal gait. We have a swing face and stand face, right? For single, for swing face and stand face for normal pattern gait. But for those other people, they're having an abnormal gait, such as what you call scissoring gait. What happened to them? You need to have a something detector sensor, whether what happened to the swing face, stand face. How about the double support? How about the single support? You can progress with the parameter. You can use that one as your innovation. Thank
All
you,
right,
Sabrina.
thank you, Dr. Riana. What about you, Sabrina? Have you been satisfied for any curiosity?
Clearly.
Okay,
Thank
thank you. Yeah, Dr. Riana, let me continue to the second question.
Okay.
We have second question from M. Gali from Major of Physiotherapy. Yes, Gali, please.
Morning, doctor.
Morning. Galih ya nama.
Yes.
Okay.
Before that, let me introduce myself. My name Muhammad Galih Pratama. I am grade 2 physiotherapist at Stikes Rumah Sakit Usada. So here, I have one question. My question is, how can the risk of falls be assessed in elderly with mobility limitation?
Can I ask you, Gali, mobility limitations such as this patient having wheelchair bound or not? They're
Yes,
on
miss.
wheelchair.
Yes.
They
Mm,
okay.
Uh,
All right.
yes.
So what is your question regarding again? What the risk
Risk, miss, of falls.
of okay, Gali, lansia yang datang, okay, totally yang lansia yang datang, all the people yang came to you with the wheelchair, for sure they consider high risk. Mengapa? Awak buang wheelchairnya, totally dia jatuh, betul? So those come with the wheelchair bound, totally high risk for fall for that patient. Okay, regardless any working aid, whether they use a quadripod, tripod, right? They still can perform all the outcome measure. For example, you want to perform time up and go test, but the time taken to complete is much more longer, right? Usually kalau kita yang lansia yang sihat, usually less than 11 seconds to complete the test. Stand up from the seat, stand up, walking 3 meter, turning, and come back 3 meter and sit down. Usually less than 11 seconds. But for those with the mobility limitations, such as using the walking aid or those with the wheelchair, for sure they need time to complete longer. Alright? Dan totally yang datang with the wheelchair, high risk untuk falls. Any walking aids yang datang, high risk. This is the rule of thumb. Okay.
Okay, Dr. Yana, thank you. What about you, Gali Pratama? Is it clear enough?
Please, clear enough.
For your questions, Dr. Yana, let me to go on to the last question
Okay, sure.
from the student of Sticker Sada also with Reza. Yes, the screen is yours, Reza.
Okay, thank you, Miss. Hello, good morning, doctor.
Morning, Reza.
Yes. Thank you for the opportunity, and your explanation was so good, doctor. Thank you.
Thank you so much. I'm glad to hear that.
Okay. Doctor, first let me introduce myself. My name is Reza Farizi from Stiga Susada, from Health Administration Grade 2. So I want to ask you, in the slide, you explain about model cares and technology integration, right?
Yeah.
So my question is, what are the potential risks of over-reliance on telehealth or digital monitoring in replacing in-person assessment within modern care models?
What apa? Sorry, Reza?
What are potential risks?
Potential risk.
Yes.
Potential risk when we replace one-to-one approach regarding tele-rehab.
Yes, of
Is
course.
this your answer? Correct.
Yes.
Okay. Potential risk. Okay, thank you, Reza. In my opinion, I do believe that still one-to-one approach is more beneficial, is more cost effective, right? Correct. I'm very sure. And here is physiotherapy. Kata tidak nanti physiotherapy nggak ada kerja. Betul. But you need to remember those with the low countries or rural area, that these patient also having difficulties in performing what we call nak pergi temu janji, transportation issue, right? The time consuming, nggak siapa yang ada bawa, and then they have a limitation. So here come tele-rehabilitation. Still, you want to approach this group. So you approach by tele-rehabilitation. It's not usually every day you need to tele-rehab. Must have internet, must have this one. No. You need to have some time innovative idea how you want to make sure still this group performing exercise at home, using all the equipment at home. Don't need to buy jama, dumbbell, sandbag, not so that. You need to try to innovative ways in your idea to perform. Sometimes you use kita angkat pakai mineral water kan sebagai beban, just to perform 30-second arm curl test. Right? And then ask the patient to try monitor during your logbook using pen and paper. That's it. And you as physiotherapy came to visit every weekly or monthly just to get the logbook and interpret and prescribe it, put in your all the AI software or tools just to predict whether this patient, because nowadays we have so many prediction tools, you can predict whether this patient having declining in strength upper limb and lower limb, thus having the risk for falling. So this is the potential risk lah. Everyone having the same issue here, but we need to tackle this small group of population. Kita bukan mau semuanya terus convert to all the online tele-rehab. No. We just focus why having this group still they have ketinggalan, dia tak datang ke janji temu. Correct. So we apply for this group lah, special group. Okay, thank you, Reza.
Okay, thank you, Dr. Yana. What about you, Reza? It's clear enough for you?
Clear and enough. Thank you,
Thank you, Reza,
Doctor.
for your question. Yes. Dr. Yana, would you mind to continue to answer the questions for the very last question, because
Okay,
it seems
come.
like
I'm
the
welcome. Okay.
physiotherapy lecturer is curious anything from your elaboration. This is from Ibu Elin. Yes, Ibu Elin.
Hello,
Yeah,
thank
you may
you,
deliver
Miss
your
Ina.
question. Thank you.
Hello, Dr. Nur.
Hello, hi.
My name is Elin Arta Carlina. I'm currently a lecturer now, and
Okay.
before become a lecturer, I work as a practice. Referring back to your presentation and relating to my current profession now, what strategy would you suggest for university to incorporate being aging and mobility prevention as essential components in physiotherapy education? Thank you.
Suggestion for universities, doctor?
Oh yes. In your country, is a physiotherapy a doctor?
No, same. Doctor is a doctor, medical doctor, still.
Oh, okay.
In a hospital setting.
And you can call me Elin, just Elin, because in my country, not a doctor Elin, but just Elin.
Same here in Malaysia. Because in multidisciplinary, our superior is still in the medical doctor. Yeah. They will medical doctor will prescribe what they want. Usually they generally prescribe for chest physio, limb physio. That's it. Correct. So my suggestion would be we cannot change anything yet. The policy maker need to do something because still we having the same issue here.
Thank you.
All right, thank you.
Okay, thank you, Ibu Ellen, for your questions, and Dr. Yana, once again, thank you for your great elaborations. I can see this topic really resonates with many of us. Well, we truly appreciate your time and valuable contributions for this session, Dr. Yana. Now, before we close, we would like to take a group photo together with our speaker, Dr. Yana, and all participants. May I kindly invite everyone to please turn on your camera and smile for the photo session. Let me take this moment. I will count on. Okay, let's take the picture. 3, 2, 1, and smile. Once again, please. Okay, 3, 2, 1, and smile. All right, thank you everyone. Once again, thank you, and please give warm round of applause for Dr. Nur Azliana Azizan for the wonderful session. Well, Dr. Nur, you may turn off your camera if you have any other activities. Thank you. Okay. Yes, ladies and gentlemen, now we are moving to the next session. We are now having the second speaker. We know her as well. She is Ibu Dr. Eni Juliani MTech, who will talk about innovation in curriculum and educational technology in the field of health sciences. But first thing first, let me show you her curriculum vitae. Okay. It is my great honor to introduce you Ibu Dr. Eni Juliani Anke, a dedicated and nursing educator and academic leader from Sekolah Tinggi Ilmu Kesehatan Rumah Sakit Husada Jakarta, Indonesia. Okay. We wait for the CV. All right. Yes. Dr. Eni Juliani currently serves as the Vice Chairperson for Academic Affairs at Sekolah Tinggi Ilmu Kesehatan Rumah Sakit Husada, where she plays a key role in curriculum development and academic management. With more than 3 decades of experience in nursing education, she has contributed significantly to advancing the quality of nursing training and leadership development in Indonesia. Dr. Eni holds a doctoral degree in educational technology from Universitas Negeri Jakarta, a master's degree in nursing from University of Indonesia, and a bachelor's degree in nursing from the same university, University of Indonesia. She began her professional journey after completing her diploma in nursing at Rumah Sakit Husada Nursing Academy. Throughout her academic career, Dr. Eni has served in various leadership roles, including Deputy Director for Academic Affairs, Academic Coordinator, and Lecturer and Clinical Instructor. Her teaching expertise covers a wide range of subjects such as health promotion and education, nursing leadership and management, medical surgical nursing, and health terminology. Known for her passion for education and commitment to student development, Dr. Eni Juliani continues to inspire the next generation of nurses and healthcare professionals through her teaching, leadership, and mentorship. Ladies and gentlemen, and all the participants, please join me in welcoming our distinguished speaker, Dr. Eni Juliani Anke. Ibu Dr. Eni Juliani, the screen is yours. Thank you.
Bu Lina sebentar.
Okay, we wait for the session. We would like to inform everyone, please stay tuned on your camera and please gain more about the elaboration from the speaker. It will be something worth to take a part in this international conference. All the participants, all the lecturers, all the students, we hope you take a part by showing excitement, curiosity, and yes, showing okay. Yes, we will wait for the second speaker for a while. Just stay tuned on your camera, please. Regarding to the okay.
Sudah selesai.
Well, all the participants, we will continue our sessions. This is the second speaker, Ibu Dr. Eni Juliani Anket. Ibu Dr. Eni, the screen is yours.
Okay, thank you, Miss Lina, for your time as moderator. My voice clear? Okay, Miss Lina still fresh guiding the conference until the second day. Okay. Uh, I only have 5 minutes to the present. Please remind me if it's over.
Yes, we will, Ibu.
Okay, ladies and gentlemen, on this occasion, the topic I will present as part of the main theme of the second international conference at Stikes Rumah Sakit Husada is curriculum and educational technology, innovation in health higher education. And then the industry, the educational world face massive and rapid technological disruption. The industrial revolution 4.0 and society 5.0 demand fundamental adaptation in how we learn and teach. Thus, higher education institution in the health science must be ready to transform toward adaptive, flexible, and personalized education. Okay, so from this background, the focus of the topic in this presentation is curriculum and educational technology innovation, AI roles in curriculum redesign, teaching and assessment, practical example across health disciplines, and how to define innovation. Curriculum innovation redesign competencies and assessment for current and future needs. And educational technology innovation is about using digital tools like VR, AR, and AI, adaptive LMS to enhance learning. Ladies and gentlemen, based on the two definitions of innovation above, how do we define digital transformation in education? Digital transformation in education encompasses three things. The first, paradigm shift from traditional to digitally supported learning. Second, pedagogy innovation focus on pedagogical innovation for effective, interactive, and personalized experiences. And third, build a digital culture in education from administration to class interaction. Okay. As an administrator and educator in higher education, you fully understand this digital transformation paradigm. So, how do we respond to it? Curriculum innovation. Yes, but why is it so innovative curriculum? There are several reasons why we must innovate the curriculum in response to current disruption. Rapid change in clinical technology, example AI, telemedicine, need for digital ready professionals in education and healthcare and in almost every aspect of our lives. Limited real practice encourage simulation-based learning. Align with WHO recommendation on AI integration in curriculum. Okay, so what are the main trends in current curriculum innovation? The first, sorry, okay, the first, outcome-based education and outcome-focused curriculum. The second, integration of digital and data literacy, like digital health competencies. Third, micro-credential and lifelong learning. Fourth, interprofessional education for clinical teamwork. There are still other innovation trends, but this could be the main one of the moment. This is in line with the Morrow and Bloomfield 2025, the holistic integration of technology, collaboration, and competencies. Recent meta-analysis indicated that the integration of technology in education not only enhance academic achievement, but also positively influence motivation, engagement, and the development of 21st century skill. However, technology must be integrated through appropriate instructional design, policy support, and educator preparedness. Therefore, the use of educational technology needs to be positioned as a holistic strategy that combine technology, innovation, pedagogy practice, and educational policy to create a more inclusive, effective, and sustainable learning ecosystem. Okay, here are some case study reporting global practice for transformation in health education. Pilot and international collaboration, example EU project, demonstrate that multi-stakeholder partnership accelerate digital capacity building and access to technology. University program integrating AI and clinical reasoning, 2023 until 2025. Studies show AI use for learning augmented, not replacement. And a systematic review of the impact of artificial intelligence on educational outcomes in health profession education reporting positive impact from embedding AI. Also reported by WHO, need preparing workforce for digital system. Next, what are the supporting factors in curriculum innovation? The first, institutional policies and leadership that support digital transformation. Second, technology infrastructure like LMS, simulators, and bandwidth. Third, faculty capacity, digital literacy, and AI competency. Four, funding and partnership with industry, hospital, and other universities. National international competency standard that recognizing digital skill like literacy and AI. Finding indicated that effectiveness, what works and doesn't work, of using digital technology to educate and train healthcare worker varies by training, objective, digital modality, context, teaching and assessment methods, study population, and practice specialty. Okay, ladies and gentlemen, there are quite a lot of roles for AI in the field education that will support the learning process to be more effective, adaptive, and personal learning, such as curriculum and planning. Sorry. Curriculum planning, learning analytics, content recommendation, chatbot and virtual assistant, automatic grading and assessment, and intelligent tutoring system. Okay. please. Okay, I'm sorry. There's various roles of AI can be found in the following innovative learning methods, flexible and personal. Various innovative learning models are currently developing, like AR, VR immersive experience, provide an immersive and engaging learning experience. And then real-time LMS evaluation, enable immediate feedback and evaluation. LMS platforms such as Edmodo or Moodle. Stikers Rumah Sakit Husada using Sevima allow students to access material, videos, and assignment online, so that learning is not limited by time and place. Adaptive and personal learning. Adaptive learning system based on analytic data to meet individual student need. Okay, next, gamification and collaboration. Strength, motivation, and learning experience. Simulation-based learning combined with AI for automated feedback. And then mobile learning, promote flexible, self-paced learning. Example, Pentasmo. Pentasmo is my application. I developed it based on my teaching at medical surgical course at Stikes Rumah Sakit Husada. Pentasmo is comprehensive learning based on mobile learning, and mobile-based comprehensive learning LMS focusing on learning time, teaching quality, and personalized pace. In 2023, Giuliani reported that Pentasmo effective, efficient for flexibility and personalized learning. And the principle of mobile learning-based master learning is formative assessment and feedback are core activities and the most frequently implemented. Formative assessment conduct during learning activities to determine the competencies currently mastered by student. The next topic will be moved on in the previous topic has been completed according to the minimum competency criteria. And so on until student achieve all the learning outcomes.
Pardon me, Ibu Eni. I do apologize to remind you, you have 2 minutes left.
2 minutes. Okay, thank you. Pentasmo, one example on personal learning. Ladies and gentlemen, here are some examples of application in several health study programs. We can read on screen. I think we are already familiar with and may have use of the application. So I want to cover them all. Okay. So what the challenge in the technological transformation? The first, digital divide, unequal access to technology and internet, data security and AI ethics, protection of personal information, low digital literacy among faculty and student, and then resistant to change from educator and institution. Include WHO note to need for strong evidence of long-term impact. Okay, so to face the challenge require a strategy response. The first, build digital culture and cross-faculty collaboration. We encourage lecture from various faculty, organize digital learning community of practice, develop digital leadership in each study program, The goal, create cross-faculty collaboration that enrich content and accelerated the institution digital transformation. Second, faculty upskilling in digital and AI literacy, regular training on AI for education, certification and micro-credential, mentorship program to ensure all lectures are techno-pedagogically prepared to design, implemented, and evaluated innovation digital and AI-based learning. Third, invest in equitable infrastructure, inclusive campus Wi-Fi access, developing a cloud-based learning ecosystem to ensure digital equity so that all students have equal opportunities to actively participate in innovative learning. Four, create AI policies for learning and assessment. The goal to ensure that the use of AI align with the principle of academic integrity, transparency, and ethical responsibility in the educational process. With world partnership at industry, university, and hospital. The goals to bridging theory and practice, strengthening student digital skill, increasing the curriculum relevant to dynamic and the technology-based workplace. Six, evaluate and publish outcomes for learning innovation or best practice at the national and global level. Okay, about AI, frequency question related to ethical and privacy issues in the use of AI in education, like bias and fairness, transparency, safety, responsibility, and security. So, ethical framework and best practice. Institutions should develop internal AI governance policies aligned with global frameworks such as the UNESCO recommendation on the ethics of artificial intelligence, emphasizing human dignity, well-being, and harm prevention. Okay, this is an example of ethical practice in higher education, and then ethical implication we can read on screen. So balancing technological innovation with bioethical principle in health education. Okay, core pillar of digital education, technological infrastructure, digital competence, adaptive curriculum, and learning innovation. Okay. The key message for success in transformation, we must have visionary leadership and institutional commitment, do collaboration across IT, academic, and management, start human resource development and culture of innovation. Finally, as a closing message, digital transformation in health education empower educators to create more adaptive, inclusive, and human-centered learning experiences. Okay, that concludes our discussion. Thank you for your time and attention. Back to moderator.
Well, thank you, Ibu Dr. Eni Juliani. That was such an inspiring and informative presentation. Thank you, Ibu. I do apologize for all the participants. I cannot open the Q&A stations because we have to go on to the next speaker. But now, before we close, we would like to take a group photo together with our second speaker, Ibu Dr. Eni. May I kindly invite everyone to turn on your camera, please, so I can count on for capturing the moment. Okay, let me count. Yes, make sure your camera is turning on. Okay, let me count. 3, 2, 1, and smile. Okay, once again. 3, 2, and 1. All right, thank you, Ibu Dr. Eni Juliani. Thank you for your insightful presentation in this session. Well, we are moving forward to the next speaker. Okay, ladies and gentlemen. Now we come to the third session. So in this session, we have the third speaker. He is Prof. Michael Joseph S. Dino, PhD, MAN, LPT, FAA, and FFN, MR, CSI, ANEP, who will talk about advanced technologies for health and wellness of older adults. But first thing first, let me show you the CV of our third speaker. All right. It is an honor to introduce our distinguished speaker, Dr. Michael Joseph Estino, a postdoctoral research scholar at the University of Central Florida, USA, and the Director for Research, Development, and Innovation at Our Lady of Fatima University, Philippines. Dr. Dino is a fellow of the American Academy of Nursing, FAAN, one of the most prestigious recognitions in global nursing, and is internationally known for his innovative work in nursing informatics, digital health, and simulation-based education. He has received multiple global awards, including being named among the top 10 finalists of the Astor Guardians Global Nursing Award 2023, and has been honored as a 10 Outstanding Young Man, TOYM, worthy of the Philippines for his contributions to health and education. Dr. Dina has authored numerous high-impact research publications focusing on telehealth, mixed reality application in nursing education, and human technology interaction. His work has advanced digital transformation in healthcare, particularly in elderly care and nursing practice innovation. In addition to his academic achievement, Dr. Dina actively engages in international collaborations and mentoring programs that empower nurses and healthcare professionals in adapting to the era of technology and global health challenges as well. Ladies and gentlemen, please join me in welcoming our distinguished speaker, Prof. Dr. Michael Joseph S. Dino, FWAN. Please give warm applauses for Prof. The screen is yours.
Okay. Salamat Detang, and good morning to everyone, especially for my friends in Indonesia and of course around the world. So thank you to our beautiful host for that very kind introduction. And apologies for the slight changes in the schedule because my flight earlier this morning was actually late. And but nevertheless, so I'm really excited to speak in this very impressive international conference. And my topic is on advanced technologies for health and wellness. So I'm Professor Dr. Michael Joseph Dino. My students and my friends used to call me Doc MJ. And currently, I'm working at the Our Lady of Fatima University in the Philippines. And recently, I accepted an associate professor position at the University of Central Florida. Uh, Basically, I'm born from the Philippines, and I know we have a lot of differences, especially Philippines and Indonesia. And I must say that when I visit Indonesia, so they always mistaken me as an Indonesian. And I'm really happy because I really love Indonesia because of the warmth of the people and hospitality of the people. I really love the food also. So before I start, I would like to mention to you some of my biases as a speaker. So just like what I mentioned, currently I'm serving as the Director for Research Development and Innovation at the Our Lady of Fatima University. So Our Lady of Fatima University, or OLFU, is a six-campus university located in Luzon, Philippines. And by next month, I'll be, of course, also serving the University of Central Florida, located in Florida, USA. And just recently, we launched a new building, the Dr. Phillips Nursing Pavilion, which is, of course, allotted or designated for the College of Nursing, especially when it comes to advanced simulation. And 2025 is a very special year for me as a nurse. Why? Because this year, I'm celebrating my 20 years of service in the nursing profession. So I graduated way back in 2005 in the Philippines from a Bachelor of Science in Nursing degree from the Philippines. And 20 years after, which is now 2025, I'm celebrating my 2 decades of service in the nursing profession. So as a lifelong learner, I always engage myself into a lot of trainings, programs, and professional development. So after the pandemic, I was provided a scholarship to study at MIT for a very short course on artificial intelligence. And my professor during that time requested us to develop a collage of our professional activities through the years. And what you're seeing right now on the screen is the same slide that I show my peers, my mentors during that time at MIT. And this picture summarizes my 20 years in the nursing profession. And do you know what's the common thing about these pictures? These are all related to technology. Since I graduated from the bachelor's degree in nursing in the Philippines, I engaged myself to a lot of research projects and technology service projects for the community. So recently, the new definition of nursing was launched by the International Council of Nurses through the international conference held in Helsinki, Finland. I'm really lucky because I'm one of the members of the Delphi Expert Group Committee who developed the new definition of nursing and nurses. So, if we're going to summarize the new definition, according to the ICN, nowadays, nursing practice is underpinned by a unique combination of science-based disciplinary knowledge and technical capability, ethical standards, and of course, therapeutic relationships. I highlighted here some of the terms that are related to the practice of nursing today. Disciplinary knowledge, technical capability, which I think is also related to the role of nurses to always innovate. So I think nowadays, nurses should not only be competent when it comes to nursing skills, but be competent also in terms of using technology. Because nowadays, being adept with using technology is required not only in nursing, but other professions as well. Why? Because currently, we are living in exciting and challenging times. And I know you would agree with me that the nursing profession is experiencing a lot of transformation when it comes to policies, procedures, government requirements, and of course, technological advances such as artificial intelligence. So let us take a look at how nurses evolved through the years. I know you are very much familiar with what we call industrial revolutions. And the world has experienced four industrial revolutions. The first one is during the first industrial revolution, steam engine was invented during that time, and it actually expedited the way on how people travel from one place to another because of the steam engine. The second industrial revolution is all about the invention of electricity that powers a lot of machines and operations in several industries. The third industrial revolution started when human beings initiated the use of computers and use it to process data and a lot of procedures in their work of interest. And currently, we are now on the fourth industrial revolution that can be characterized by cyber physical system. So when I say cyber physical system,
Di bawah
the
ini.
advanced technologies that can be used for the nursing profession. And what are those advanced technologies? These technologies would include artificial intelligence, robotics, self-driving cars, the use of satellites, mixed reality and extended reality. And currently, before we are using, of course, plastic models, currently, we can also 3D print anatomical models or even convert it into digital form and manipulate those digital objects out of thin air. So I remember when I started teaching in the nursing profession 10 years ago. So I'm one of the first nurses in the Philippines who actually developed the first technological simulator or technology-driven nursing laboratory in the Philippines. So that was me, I think, 10 years ago. But fast forward during the pandemic, so everything changes. In addition to high fidelity simulators, we are also using or maximizing the internet and the World Wide Web to connect to our students, especially during challenging times, especially during the COVID-19 pandemic. I remember during the COVID-19 pandemic, I'm in Baltimore during that time because I'm finishing my doctoral degree in nursing at Johns Hopkins University. And I also teaching virtually to my students in the Philippines through the Zoom platform. And with the help and assistance of my colleagues from the Philippines, they are helping me during the discussions on how to demonstrate to the students the proper way of attaching the different leads of the ECG and interpreting electrocardiogram. So I also remember way back in 2009 when I started collaborating with our Japanese colleagues at Tokushima University because we are piloting the use of robots in performing exercise, especially for older adults. So nevertheless, if we're going to take a look at all the innovations and changes that's happening all around us, we can say that nurses must evolve from a simple competency-driven individual to a nurse which is also technologically competent. And when we hear of the evolution of man, there's only one scientist that always cross our mind, and that is Charles Darwin. Is that correct? Yes. Charles Darwin is the scientist that mentions all the changes in the environment will actually shape the development of an individual, may it be biologically or professionally. And for us nurses, for me, I think nurses should also evolve, no? So being competency-driven profession to a technology-inclined individual. And the pictures that you are seeing below is actually my sketch in my iPad because I tend to convert some concepts into nursing context whenever I have free time. So also, this is also a challenging time for us because a lot of technologies and gadgets are being launched. Just recently, last February 2024, Apple Incorporated launched the new spatial device known as the Apple Vision Pro, and it changes our practice forever. Why? Because using this head-mounted device, such as your virtual reality devices, such as, of course, we have your MetaQuest, it can actually project digital objects into your real environment. For instance, if you have a palliative care patient, example, you have cancer patients, so using mixed reality can actually alleviate the stress and somewhat relaxes our patients who are undergoing chemotherapy. So the idea of mixed reality only heightened during these days, but I started exploring it way back in 2015. At the start of 2015, I'm already developing some gadgets that can project digital objects to what we call virtual space. So at this juncture, let me give you a very brief background and overview of what reality virtuality is. Reality virtuality is a concept that comes from two researchers, Milgram and Kishino. And when we say virtual reality space, this is a space where physical and digital objects can combine. If you remember the mobile application Pokemon Go, I'm one of those who actually play Pokemon Go. And through the use of the camera of your cell phone, you can catch monsters because you can see the digital monsters in front of course, the screen of your smartphones through your mobile phones, right? So there are three most common reality virtuality applications in the nursing profession. And these are virtual reality, or the ones that we're calling VR. We also have augmented reality, or what we call AR. And also we have mixed reality, or MR. So let me give you some examples of each. So the first one is virtual reality. And this is being used especially for young students because it utilizes that head-mounted device that actually um, closes your perception of your external world. So through the use of virtual reality, you can actually be transformed from one perception of place to another, just like what you are seeing right now. And when I was a student at Johns Hopkins in Baltimore, so we also experienced using this VR for us to be exposed to a lot of clinical and nursing scenarios. Augmented reality, on the other hand, can be used through, of course, the mobile phones or applications. Just like, for instance, if you're going to type in circulatory system in your Google browser in your cell phone, there's an option there where you can use the camera of your cell phones to project anatomical models such as of course, we have the cardiovascular system. And this is also being used by a lot of colleges of nursing also to project virtual objects, no, in the digital world. So the other more advanced type of reality virtuality technology is what we call the mixed reality. And in a lot of hospitals, especially in the US and Canada, they are already using mixed reality to communicate with other healthcare providers, such as the doctors, the radiologists, the nutritionists, and other members of the healthcare team. Also in the US, they are starting to use it as a hybrid platform for education for their students. So imagine that the faculty member only wearing that headset, and the students are attending their classes wearing that headset and being represented by avatars at the comfort of their homes. And instructors can also project digital objects that they can manipulate and expand. So based on the type of topic that the professor is actually discussing. I am really lucky because I was given by the Philippine government a multi-million grant amounting to more than 20 million pesos to establish a research laboratory I call the Marvel. So Marvel for us refers to multiple applications for reality virtuality experience laboratory, and this is a research laboratory that pilots mixed reality application for nursing and medicine. So the MOU was signed way back in 2002 in the Philippines. And after 6 months, it was launched at Our Lady of Fatima University in the Philippines. And this is how the laboratory looks like. So there's a motion capture area, there's app development area, and of course there is a testing area at the at the latter portion of that particular room. So this became famous in the Philippines because it was shared through television and social media. And there's a TV show in the Philippines that highlights this laboratory on how it envisions to change nursing practice, nursing education, and medical education forever. So in the Philippines, we're developing a lot of applications for nursing education and also for community service. And we also conduct research, especially for older adults, using our Marvel laboratory. So at this point, I would like to share with you one of a very concrete example of application of technology in caring for older adults. So 2 years ago, our university in the Philippines actually caters to a lot of community dwelling older adults as its community extension. So just like, for example, for the Valenzuela campus, the main campus of OLFU, we have 4 communities that we serve. So in that community, around 30% are considered older adults. And we have a separate group of older adults that we actually assist for them to be more healthy and more educated when it comes to their needs. So the question is, why do we focus on older adults? We focused on older adults because the Philippines, Indonesia, just like other countries, is experiencing population explosion. And if we're going to take a look at the ratio of young individuals as compared to older adults, we can say that the population is graying in the Philippines and Indonesia and all parts of the world. And the most surprising is that 30% of those older adults are residing in developing countries. The Philippines is considered a developing country, so therefore focusing on the health of older adults is very much important. So one of the things that we focus on recently is the regular exercise among older adults. Why? Because after the COVID-19 pandemic, older adults became sedentary in terms of their lifestyle, and they become inactive. So what we did is we conducted a literature review of the minimum requirements of minimum minimum requirements of exercise among older adults in the Philippines. And using the Marvel Laboratory, we developed a virtual coach. So what is a virtual coach? A virtual coach is a digital person that actually that can teach you exercise and you can follow to perform specific exercises. So using the Marvel Laboratory, we hired a professional exercise coach. Okay, we actually captured the movement of the coach and convert it into a digital form. Okay, so we capture the authentic movements of an expert when it comes to exercise, and we develop the virtual coach. So this is an example of the virtual coach. And if you are the user of the virtual coach, you can change the gender from female to male. You can also change the music, the background music. You can change the speed of the different steps. Or if you want, the system can ask you several questions, and through the use of AI, they can develop a routine of exercise for you. Okay? Hopefully, in the future, we can develop a separate app in Bahasa Indonesia, because I know the Philippines and Indonesia has a similar characteristic. So I think this application will also be effective in Indonesia. So in the Philippines, we first conducted the pilot testing at 2 senior centers located in Valenzuela City and Quezon City. And to refine the project, we also did eye capture system, okay, to identify the interaction of older adults. Then we launched the program. We call it Hataw at Sigla, para kay Lolo at Lola. And Hataw in Sigla in English would mean move and groove for older adults. Through the use of different sensors, we captured health data such as fall risk. We also captured the heart rate variability, the temperature, the pulse rate, respiratory rate of the elderly. And we also give or deployed some surveys. And all of these variables are actually focusing on 3 major groups. We have study variables that focuses on computer system factors. We have study variables that focuses on the interaction of the older adult to the virtual human, and the human factors that includes demographic and other social determinants of health. So when we started launching this program 2 years ago, we already produced more than 10 Scopus listed publications, because we conducted the research in the exploratory sequential mixed method approach. So we utilize both quantitative and qualitative data. We have 4 aims. The first 3 objectives of the research focuses on quantitative results on how the technology and intervention would impact the health of the elderly. And the last aim would focus on the qualitative experiences of the older adults. So we are very lucky because this project and the research papers that we produced out of the project was published in top tier journals. So we initially started with around 2 groups of elderly consisting of 35 older adults at each group. But right now, we expanded to more than 20 groups of elderly from the different parts of the Philippines. Part of our study is to identify their preferences when it comes to the use of mixed reality for older adults. And we discovered that the use of mixed reality is also applicable for older adults. However, they have difficulty in using the VR system. So that's the reason why we use the mixed reality. And the difference between the two is that for mixed reality, it's just like wearing a see-through glass, You can see your environment, but you can also see the virtual coach in front of you. Okay? So if you're really technical about research, so these are the results of our conjoined study. And we also discovered that our older adults, because of their sensory challenges, have a different way of interacting with virtual coach projected through the use of mixed reality. We also check the differences between the performance of the groups, and we found out that using mixed reality for exercise is a decent complement or replacement of the actual exercise for older adults. In our qualitative study, we discovered that our older adults, based on their experiences, are really looking forward to using the device and the technology in the near future. So hopefully, this project can be extended to other countries as well. And through the Sigma Theta Tau International Honor Society in Nursing Asia, so hopefully we can collaborate with our peers and colleagues from Indonesia to apply this technology in the country. So, how are we envisioning the technology moving forward? So, this technology received recognition and award coming from the Philippine government only last month. So I was given this Excellence in Project Implementation and Completion Award, or EPIC Award, given by our Department of Science and Technology. And because of my training at MIT, so I am now integrating the use of AI in the system, wherein in the future, the older adult can actually talk and converse with a virtual coach, in addition to teaching them on how to do proper exercise. And being an associate faculty at the University of Florida, I'm looking forward collaborating with my mentors, my advisors, and other departments at the University of Central Florida to develop additional applications that can be used for wide dissemination and commercialization. Right now, we receive additional funding from the Philippine government to develop another laboratory. And this time, this laboratory envisions to refine and develop technologies for the care of older adults. And hopefully, this can be disseminated all throughout the Philippines. So one of the lessons that I have learned from my experience with technology is that technology is good if you're going to combine it with nursing care. Technology cannot replace the nurse, right? So technology will not or ever replace the nurse, but a nurse using technology or integrating technology into practice can replace a nurse who is not using technology. And if we're going to take a look at researches, so it is called hybrid intelligence, wherein if you're going to maximize on your nursing skills and constructively integrate the use of technology and the manner on how you serve other people, your clients, your patients, your older adults, so the effect and impact to their quality of life will actually be maximized. So before I end my presentation, I would like to share with you one of my favorite quotes from one of my favorite movies. Do you know that movie? Spider-Man, yes, very good. So according to Spider-Man, with great power comes great responsibility. And for me, using technology is power. Thus, nurses should be responsible enough to maximize the positive effects of technology and mitigate the negative impact of technology in the practice of the nursing profession. And if you would ask me, is advanced technology the issue of the future? No, it's about trust. Because if maybe we can have a reflection later on that if we're going to use technology, will our patients still trust us if we're going to use it? So for me, that is the most important. Okay? So with that, thank you so much again for your kind invitation. I enjoyed my talk and looking forward to collaborating and seeing you in person very much soon. Bye-bye.
All right, thank you, Prof. Michael. I do agree with you. Yeah, technology is always related to the responsibility of the human itself. Thank you. Let me continue the session, Prof. Michael, to the Q&A session. Only for what? one question, please. Would you mind?
No worries. Yeah, thank
All
you.
right, ladies and gentlemen, now it's your turn. We would like to hear from you. I will open the Q&A session for one question only. All right. Is there any question, please?
Okay, thank you so much. Mrs. Lina, can I give a question for Prof. Michael?
Okay, thank you. Mr. Marcelinus, the screen is yours.
Okay, thank you so much, Prof, for the very good lesson for us because your presentation it's very give our motivation as a nurse, as a lecturer, and as a student. Thank you so much because we have many listened and it's very good for us. And maybe I just want to tell you that our stickers of Rumah Sakit Usada focus on palliative. So that's I'm so agree with you because in the Asians, such as Philippines, Indonesia is very focused, and Asians very focused about the adults. And we looked at in the nursings, the technology is very important. That what you say before, and but not all around the world, the nursing can improve their skills, and they cannot use equipment tools in medis because not all the nurse have a chance to get a good trainers or a good programs in the organizations nursing at the country, especially I think it's not all in Indonesia, but it's all around the world. It's not all the nurse can get a chance to more improve themselves in especially in technology nursing. So maybe Prof can give the suggestion for what the good programs must the government must do or the organization nursing at the country must do to make the nursing all around the world can get the accessibility to get a good program or a good training focused to they improve themselves, especially in technology 5.0 in nursing. Thank you
Okay.
so much.
Yeah, thank you so much, Mr. Marcelinus, for that very interesting question. And of course, I would like to answer that. So, based from my experience as a nurse in the Philippines and in the US. So, you are correct. I agree with you that there are lots of nurses who are not acquiring technology skills because of the lack of training. And there are those also nurses who are not ready to change their mind or change their mindset on the application of technology in their nursing practice. So I think there are solutions that we are using now in the Philippines. So I'm developing a lot of projects for continuing professional development of nurses in the Philippines. Because in the Philippines, before you can renew your license to practice nursing, so you are required to give around 15 to 30 continuing professional education units. Okay, so since I have lots of grant coming from the Philippine government and international grants, I'm offering free training for nurses in the Philippines that they can use to earn the CPD units required for the renewal of their license. So previously, we started with in-person events, right? So we have very short packet events. For example, we have electronic health record training for maximum of 3 hours, morning and afternoon schedule. But nowadays, because of the COVID-19 pandemic, so it actually changes the manner on how we deliver our CPT programs. We provided it in hybrid. We have in-person for those nurses who would like to attend the training on-site. We also provide it through the use of learning management system. So in our university, we have a very good learning management system, and we also develop the digital version of the technology training for nurses. And we're also doing it in hybrid format or combination format. You can attend or watch the theoretical videos online. However, when we discuss the skills, you need to be in person. So it's around 6 hours exposure. You need to review the videos and you need to be in person for the skills training. So for me, I think a lot of nurses can be equally competent in technology if we're going to provide them good training programs. Because there are instances that these nurses are not attending training because it's not enticing to them. Okay? So the manner on how we develop training programs should accrue or stimulate attention and intention among our nurses by using creative approach, by providing them case studies, real world and authentic case studies that using technology will really improve the manner on how we deliver our services. And also in the Philippines, it's very important for us to give rewards for those nurses who are actually getting CPD units related to technology. So I think private and public partnership is very much important. Just like the model that we're using, we're not only providing training that's sponsored by the government, but we have lots of collaborators all around the Philippines that provided us a lot of funds and scholarship for those nurses who are training about, of course, technology. So, however, at the end of the day, Mr. Marcelinus, so let us understand also that the success of technology training will not depend on the training and the resources, but on the person itself. 80% of the success of every training is related to the interest of individual to change their mind, change their practice, and finally embrace the use of technology. So I hope I answered your question. That's really a good question. Thank you.
Okay, thank you so much, Prof. It's very nice and wise advice for us, especially we are a nursing. We hope all the nursing can have a mindset same that what your give advice for us, and we all know that Philippines it's very good in nursing, and we hope to Indonesia, especially our college, can give a good student in English. And I hope that we can work together maybe next time. And we hope we can get many lessons from you at the future. Thank you so much, Prof, once again.
Yeah,
Miss
thank you.
Well,
Very much welcome. Yeah, I remember we used to cater Indonesian students in our university and stay there for disaster training for a month. So we have good relationship with our Indonesian partners, and we're looking forward to resume that partnership now that the COVID-19 is over. Thank you.
all right, once again, thank you for this engaging question and delivering your question, Mr. Marcelinus. Is that clear enough for you?
It's very enough. Thank you so much.
Thank you. Okay, Pro Michael, would you mind to continue this Q&A session for one question?
Yes, of course.
Yeah.
Yeah, we can extend up to 2 hours if you want.
Oh, all right. Thank you, Mr. Marcelinus. As Prof. Michael. Yes, let me continue this Q&A session for the next question is from Ibu Halida. Yes, Ibu Halida, you may deliver your question, please.
Thank you, Miss Lina, for your opportunity. Thank you, Dr. Joseph, for your insightful presentation.
Yeah.
I would ask you, based on your experience collaborating with international institutions, what are the key elements for building effective global and interdisciplinary partnership to advance health technology research in nursing? Thank you, Prof.
Okay, wow, that's really a very good question also. So, based on our experience with Indonesian colleagues, but before that, let me say that it's not difficult to collaborate with Indonesian colleagues because I think we share a lot of commonalities when it comes to our culture, the food that we eat, when it comes to singing. We share a lot of culture, and I think from our previous partners, there are some key elements that are really important. So first one, everything should be built on trust. Okay. So I consider my Indonesian colleagues as my personal friends already because through the years we're still communicating, we're still collaborating, and every now and then we're exchanging emails. We're doing research together, we're publishing together. So yeah, so everything should be built on trust. Okay, number two, there should be a formal document that states the partnership. right? So, for example, you have memorandum of understanding, because in the Philippines, most institutions are operating based on MOU, right? So it needs to be formalized. It needs to be there. And number three, I think the third most essential would be mutual understanding and mutual cooperation. What does it mean? So if we're actually sharing a lot for our Indonesian colleagues is also sharing a lot from us. And we're learning together when it comes to the partnership that we're having. So I think Indonesians are not really hard to partner with when it comes to research, when it comes to education. And now, because of technology, we can also collaborate even through Zoom conferencing, right? We can start the research, we can plan the research, we can deploy the research and do benchmarking studies. So it's not really hard to do partnership, but this partnership should be built on trust, should be built on mutual understanding, and there should be a legal formal document that states those partnerships, because operationally and practically, most universities in the Philippines are working under the direction of the MOU. Yeah. Thank you, Zalida, for that question. Terima kasih.
Wow, thank you, Prof. Michael. Yes, Ibu Haida, is it clear enough for you?
It's clear, but I want to know once again about how about your collaboration with John Hopkins University? I want to know that,
No worries,
Dr.
no worries.
Joseph.
Yeah. Thank you for asking that. So, we had cooperations with Johns Hopkins because I was offered a scholarship at Johns Hopkins to study PhD nursing way back in 2020, and that is during the pandemic. Okay, just an overview. Johns Hopkins University is the #1 nursing school in the US. Okay, so I finished my second PhD there, PhD in nursing. That's my second PhD because my first PhD in the Philippines at the University of Santo Tomas is not nursing. We don't offer PhD in nursing before. Okay, so I completed a PhD in development studies. So when I was given this opportunity to study PhD in nursing under scholarship at Johns Hopkins, so I grabbed the opportunity. So that is the reason why we have a very strong connection with Johns Hopkins, because until now, I'm still connected to my advisors, to my professors, and most of the time, and sometimes I invite them to visit the Philippines also to speak to our conferences and to speak to conferences in Asia, because I have lots of friends all around Asia. So that's the reason why we have a good collaboration with Johns Hopkins. But I think Johns Hopkins is open to all universities. So if you're going to visit the website of Johns Hopkins, there's a dedicated page related to international partnerships. So you can reach out to the international office, and they allow visits of faculty and students at Johns Hopkins so that you can see their facilities, their top of the line facilities, and the manner on how they deliver nursing education from the bachelor's, from the DNP, from the doctoral program, and of course, including those healthcare trainings that are related to nursing. So if you would like me to connect you, just let me know. So you can send, of course, you can send an email to me. Okay. And you can get my email from the organizers of this impressive
Thank you,
webinar.
Dr. Joseph.
Thank
Thank
you.
you so much.
Thank you.
All right, thank you once again, Prof. Michael Jasab as Dean of PhD, for your insightful presentation and for answering all those engaging questions. We truly appreciate your time and valuable contribution to this session. Now, before we close, we would like to take a group photo together with Prof. Michael. So please, all the participants, turn on your camera so I can capture the moment.
Yeah. I think Dr. Hardin Ramba is raising his hand.
Yes, Doctor.
I do apologize for Prof. Michael. I have to
Okay,
close
okay.
this Q&A session
Sure,
because
sure,
we
sure.
have
No
more
worries.
speaker. Yes.
Dr. Hardin, you can send me an email, please.
Yeah. All right, Mr. Hardin, you can send your question from email. Yes, as what I said before, we will take our photo together. Please turn on your camera so I will count on. Let me count on. Yes. Okay, 3, 2, 1, and smile. once again. Okay, be ready, please. 3, 2, and 1. Oh, great. Thank you, everyone. Thank you for Prof. Michael once again. And all the participants, please give warm round applause for Prof. Michael. Prof. Michael, you may turn off your camera if you have another activities. All right. See you. Bye-bye, Prof. Michael. All right, ladies and gentlemen. Wow, that's such an inspiring presentations. Now we go on to the next agenda. We are now in the fourth session for the fourth speaker. Yes, we have Ibu Dr. Right? So sorry. Yeah, let me introduce Ibu Dr. Dia S. Saminarsi, who will talk about policy strategies to improve the quality of primary health services. It is a great honor for me to introduce our fourth speaker, but first thing first, let me show you our speakers. Stevie. Dr. Dia is the founder and Chief Executive Officer of the Center of Indonesia Strategic Development Initiative, or CISTI, a leading non-profit organization dedicated to health system strengthening, policy advocacy, and action-based research. She also serves as the chair of CISTI's Board of Trustees. With a background in psychology, Dr. Dia earned her Master of Science from the University of Massachusetts Amherst and Bachelor of Science from Seattle University in USA. Her professional journey spans consulting firms, government institutions, and international organizations. From 2018 to 2022, she served as a senior advisor on gender and youth to the Director General of the World Health Organization, or WHO, in Geneva, where she led global initiatives promoting meaningful youth engagement and gender mainstreaming in health. Previously, Dr. Dia served as a special advisor to Ministry of Health of Indonesia for partnerships and sustainable development goals. Dr. Dia has represented Indonesia and Asia in numerous international forums and has been instrumental in advancing health diplomacy, sustainable development, and gender-responsive policy. Her remarkable contribution has earned her several international recognition, including the Global Open Government Silver Award 2015, Best Innovation on Interprofessional Collaboration on Health 2014, and Best Social Innovation Award 2013 by the Economist Intelligence Unit. Ladies and gentlemen, please join me in warmly welcoming our fourth speaker, Dr. Dia Satyani Saminarsi. Ibu Dr. Dia Satyani, the screen is yours.
Thank you for the very warm welcome and good afternoon, everyone joining in from Stickers of Husada Hospital. I would like to share my screen now. Okay. Can everyone see?
Yes, you can see it, Ibu.
Okay. I don't understand why this, okay, resume. Can you see the screen move now to the second one or not?
Okay, we just see the combination of some slides in the screen.
Is this the primary healthcare? Can you see the slide move, or you cannot see the slide move?
We cannot see the slide move yet.
Okay. Okay, hold on one moment.
Don't hesitate, Dr. Dia, if you have any troubles, we can. Okay.
Okay. Okay, I think now we are good.
Yes, it works, Ibu. Thank you.
Okay. So good morning, almost afternoon there. It's an honor for me to be invited into sharing this about the primary health care, its challenges and its gap and its challenges in in Indonesia, and the proposed strategy that we continue to offer to the government, but also government at national level and also government at subnational level and civil society, students, and the general public. So what we understand so far that primary healthcare is oftentimes misunderstood as only a provision of clinical service within puskesmas or in other primary care clinics, while actually primary healthcare is beyond only service delivery and curative actions within the clinic walls, and it has three components, which we say it's an integrated health service that cuts across the life course, and it requires multi-sector approach and also active engagement, active involvement, and with communities, among communities, between health workforce and communities within individuals. So primary health care can be achieved if we see and we look at the at a comprehensive and integrative lens. We also have to remember that primary health care is not a one-way street. Primary health care begins with with people at the center, and it's the heart that people is actually the heart of the primary healthcare system transformation. Sometimes people say primary healthcare strengthening is also health system strengthening, and that is not wrong, because primary healthcare is the base that makes the pyramid of health system strong. So if the base is weak, then the whole health system is actually volatile. You will what is the example of volatility in the primary healthcare? So you refer people from primary healthcare to the hospitals more than you should, meaning people who seek healthcare in primary healthcare, within primary healthcare, they are referred to hospitals almost immediately without any intervention being done at primary healthcare. So there is no clinical service being done, no meaningful clinical service are given, no meaningful treatment or screening or information to prevent the same situation from happening again. And then people just refer the health workforce at primary healthcare just refer patients on up. This is due to the fact that we forget people is actually they need to be heard. They are the center of the primary health care, and we have to give them service according to what they need. So also according to their preference and based on the right of individuals, families, and communities. The framework to tangible solutions in Indonesia, the application is sometimes we look at health system or care or clinical care only at the hospital level, while actually primary care quality is central to health outcomes. It is the go or no go, the breaking point of equity and of system sustainability. How is that so? First and foremost, primary health care deals with quality care, deals with access for care for all, and it deals with affordable care. The part where we say affordable care, sometimes that is misunderstood by substandard or below standard quality care. While actually, whether you are in primary care, then you have to have the same quality, the same best quality as if you are reaching out to for clinical service at hospital level. Why is it important? Because Indonesia in particular, we are facing rising of NCD burden. We can see from Riskesdas or from the Survei Kesehatan Indonesia that non-communicable disease accounted for about 76% of death in the trend, in the increasing trend from 2000 to 2019. And late detection of non-communicable disease constitute or impacted into high number of cancer patients, high number of diabetic patients or other cardiovascular. Most detrimental actually is that those non-communicable disease cases are very expensive to care, to provide care for, and their medication expensive. And when you fall into non-communicable disease, then basically you are in for clinical care for the rest of your life. And this put a burden in the financial system because Indonesia now has BPJS. But if you have, or if we have good primary care, then people who access care at primary health care level will be given the intervention and the care that are actually needed. They will receive the screening that they have. They will receive the treatment that they can have. So people that are referred to hospitals become lower in number. Also, primary health care is the only care that is based on equity, meaning if you are poor or you have a low socioeconomic status, you get quality care in primary health care. That is the government saying or giving their promise to the public that no matter where you are, whether you are far away, whether you are within city limits, or whether you are in remote area or remote locations, you are given quality care. You are promised and you are given. So this is equity in itself. And what will be the impact? Impact will be resilience, community resilience, and increasingly build up strength for the health outcome in general. At present, we identified these four bullet points to providing us with a picture of the quality, the snapshot of what primary care situation, accreditation, facility readiness, and digital gap. 56.4% of primary care facilities, they have accreditation, but only 3% reach the full accreditation status. Out of that 100%, only 56.4 have accreditation, and 3% out of that 56.4% receive the full accreditation status. This is very, very important because what that says to us is that it speaks that actually there is no documentation, there is no proper documentation, data gathering, and also care that are provided to receive a full accreditation status. Out of the 514 regions, 171 sub-districts, or this is kecamatan, lack at least one service-ready puskesmas. I know number of villages is about 80,000 villages. So let's say kecamatan where puskesmas sits, let's say half of it is kecamatan. So only there is still 171 sub-district that does not have even one puskesmas. And 90% of these sub-districts are in Papua and West Papua. So we are talking about equity principle again. There is also digital and infrastructure gap. We are situated far away, so interconnectedness become one issue. and digital connection and infrastructure becomes another. 20% of puskesmas, they do not have reliable broadband internet. 1 in 5 lack reliable, just common internet, and 4,000 villages still lack electricity out of the 80,000 villages that we have in Indonesia. And of course, when we are talking about breaking down financial barrier, the expanding coverage of JKN does not mean or is not equal to universal coverage. Universal health coverage means that no matter where you are, no matter what economic or social economic status that you have, you can access the same quality care as those who live in big cities or near a health facility. The number of participants in JKN does not mean that we have reached universal health coverage. There is a big difference between universal health coverage and number of outreach of patients that have JKN, that have BPJS. Okay. Number one challenge, why is this a recurring situation? Number one challenge is human resources. We talk about system, but we often overlook to talk about and address the problem of human resources, shortage, uneven distribution, and where does the community health workers play a role in this? We can see from the slide that large province in East and, for example, East and Central Java, they have shortage, and this is because the scale outstrips the supply, and they have remote province where the numbers are low and the retention is poor. So if you are a health worker in remote province, you either want to move out from a remote province or you quit. See, so this is where the poor retention comes. Or if you are coming from a low socioeconomic status location, then almost unlikely that you can become a health worker, whether it's a nurse or it's a midwife or a nutritionist, epidemiologist, pharmacist, or even a medical doctor. The WHO benchmark is one physician per 1,000 people per population group. But that is still not the case in Indonesia. Indonesia is now perhaps one medical doctor every 25,000 in a very densely populated area. Mental health capacity is limited to give mental health counseling or medical intervention. Only 43 psychiatric hospitals were documented in 2020, and the community mental health service is near minimum, and it's very limited. Now we talk about the number of medical doctors, the specialized medical doctors. They are low in numbers, and also they are not evenly distributed. Community health workers are a different thing. One, there is a big structural barrier when community health workers are not being included in the same category like human resource for health. They are forever seen as the outsiders. They are seen as volunteers, and they are not receiving pay based on merit. And when they are in poor location, they receive also very, 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 very low income. They do not have support. The very, very, very low is like 150,000, 100,000 per month, and they are paid once every 3 to 4 months, which is what they have right now. And most areas are like that. but in big cities. So if you to go to Jakarta or you go to Surabaya or perhaps you go to Medan or Makassar, perhaps about 400,000 per month, still very, very low. And on the other hand, they are being given a lot of responsibility. And recently, they just the Ministry of Health issue a competency requirement where they have to undergo and be able to master the 25 skill competency framework. In the short term, human resource for health data has to be cleaned up, and we deploy the automated work staffing needs tool where we can pinpoint and calculate how much time does a health worker need to carry out clinical tasks, but also to carry out other management requirement or management or administrative duties. Right now, we see overload of workload for the human resource for health, and we pinpoint that mostly the origin is mostly from doing administrative and management work as opposed to doing clinical tasks. Okay. Challenge number 2 is the facility and the supply readiness. We have limited number of facilities, not enough to cater the need of the people. Availability of bed is about 1 per 1,000, 1 bed per 1,000 people in the population. Primary care readiness falls short on logistics. So right now, for example, they are already short on logistic for equipment, diagnostics, screenings, vaccine supply, and all that. And plus, there is another added responsibility for free medical checkups right now. So the logistic issue is always a challenge. And private clinics, we know that Indonesia has about 2,200 hospitals, and we have about 11,000 puskesmas, but we also have double or more or less the same number for private clinics, which is the same like puskesmas. If we reach puskesmas, all puskesmas, actually we are only reaching 50% of the population. So the private clinics are right now undergoing or having a different set of regulation, where puskesmas is regulated by a ministerial decree and private clinics are regulated by the BPJS contract between that clinic and BPJS. So there is a mismatch in how we integrate the public and the private facilities, and this is always a problem when we are talking about supply side and facility side readiness. We have a fragmented health information system. Perhaps some of you have heard in the media, for example, or within yourselves in the health community, how many apps exist in a clinic or in a puskesmas. There is 400 reporting platform that we know of. And this instead of bringing down the administrative burden, it increased administrative burden of the frontline staff. This is what I meant when I said staff or health workforce spend time in doing administrative and managerial work, because they have all the different reporting platforms that they have to report to or put data in. Okay, number 3, the challenge is about continuity and about standard. We need a national guideline, which right now exists only for 60 out of the 144 requirement or required conditions that have to have national clinical guideline. So that is still pending work and ongoing work that needs to be fulfilled. We do not have yet clear clinical pathways or electronic prompts where it allows staff or health workers to be able to see end to end. Okay, if I put a patient on this journey, then how many days or what will the challenge that they encounter and so on. And we don't have this decision support tool yet in place. Referral system, although you can refer up whenever a person was discharged from a hospital and being referred down to their puskesmas or their private clinic back again, there is no, excuse me, there is no family medicine doctor to take care for them and to follow their healing journey, whether this person is already back to back to the same situation, or whether the social determinants have somehow upgraded and corrected themselves as well. Accreditation, which I mentioned, focus mainly or primarily on admin, and it overlooks patient and community relations, the continuity of one's or a patient's journey into it, and clinical appropriateness. This is what I meant when I said it's not centered on the people, because it's like administrative checking, ticking the box, instead of really following the journey of one patient from the moment that patient became ill until that person becomes healthy again, according to what they need. And this continuity requires expanding the coverage of those illness or national guideline, and it embeds the decision and support into workflow, into the clinical pathway, into the referral system, into the integration between public and private facilities. There are strategies that we can offer, that we can propose, but also we need to understand where the gaps are and what policies do we have right now, so we don't have to start from the beginning, and how reform can be achieved. So right now we have already accreditation on regulation on accreditation. We have the minimum service requirement standard. We have the digital health momentum on our side because of the health law back in 2023, and the utilization of digital health strategy to guide national effort. But there are still remaining gaps, and it is important to uptake the integration of private sector, to continue to expand and finalize the number of national guideline, and to continue integration of data and proper governance mechanism for this data, these different data sets, and to increase, yes, we need to increase the number of medical doctors and other workforce capacity, but also we need to increase their quality to operationalize digital and clinical standards. So the immediate priority is to address readiness standards and continuity, and we prioritize on primary healthcare readiness, what diagnostics we need, what medicine, how to calibrate the equipment, and so on. And we consolidate all the different health information system, the 400 health information system, into only a few. And then most importantly, we also formalize and recognize how community health workers play a strategic role in upholding the services in primary healthcare level. Okay. Strategy number one that we can offer is actually about HRH, or human resource for health strengthening. First, we have to know the data, how many come into the system, how many are retained by the system, how many go out from the system. So right now, our attrition rate is about 27%. So usually people come in and then a third will fall off the grid. We don't know, perhaps they move to other sector, perhaps they stop practicing, perhaps they got burned out. We don't know where they go. Almost 30% of health workforce, after they come in, they go out from the health system. We need in order to be able to track them, we need to have a centralized data platform, which include the workload analysis, and how many staff that each of the province and each of the regions need to be able to staff properly their health facilities. So it's not enough just to build hospitals and to build primary care facilities, but you do not calculate how many of each job function that you need to staff. So this is what why we keep on saying that it's very important. So we use simple operational KPIs, and we depend on the coverage of family doctors by sub-district and by community health workforce retention. Number two, of course, the strategy is about facility and supply readiness. We see the need to scale WHO package of essential NCD intervention and preventive screening. There needs to be dashboards to see the progress. And first and foremost, there needs to be target for complete digital and electricity coverage for PHC. This means it's not only regular internet, it is broadband internet 100%, and that will enable EMR to really, electronic medical record, to really work, tele-diagnostic, telemedicine. We can monitor supply chain of medicine and treatment, and paper nodes such and option like fiber, satellite, solar storage for off-grid location is open. So this needs collaboration with telco, but also with electricity company. Catalog, e-procurement, and transparent supply chain is key to ensuring that logistic remain there. Last recommendation is the standard accreditation and decision support. Yes, we do have accreditation, but accreditation needs to shift from only checking the box for admin and documentation into monitoring quality of service. But we also, before that, we need that national guidelines to be finalized for all 144 conditions as constituted by BPJS. And then reform accreditation must be there, and then we can track the progress from this national guideline, and then we integrate between public facilities and private facilities. The last strategy is about monitoring, data, and digital governance. This part, we talk more about how to ensure there is continuous improvement to services being given. And we cannot do that if we do not do monitoring, data, and digital governance. Yes, on all digital health benefits, but also we need to put another a tool or instrument where we can measure if a policy works or not, if a policy generates impact or not. We can do it through impact evaluation, through implementation research, through cost-effective analysis, and through cost-benefit analysis. All of this should be integrated into a monitoring a mechanism in which include data and digital governance. I think I will end there and will be happy to answer questions that you may have. Thank you.
Well, thank you, Ibu Dr. Dia Essaminarsi. This is such an extraordinary and thought-provoking presentation. I'm sure most of the participants will be courageous to discuss a lot of things with Ibu. Ladies and gentlemen, now it's your turn. We would like to hear from you. I would like to greet Ibu Paramita. Yes, Ibu Paramita, you may deliver your question.
Okay, thank you, Miss Lina. Good afternoon, Miss Dia. It's great to meet you as a person, actually. And as you know, but I have joined your one of your program in Puspa as a supervisor. So it's great to me to see you in person. Actually, there are so many program in Indonesia, especially in health program, including health policy itself. So, but I think the biggest concern that we know is monitoring and evaluation itself. So I want to know about your opinion about that, and I want to know maybe you can give us a recommendation or tactic that we can use or adopt for from another country, and then especially in health programs. Thank you, Mrs. Dia. That's my questions.
Okay, thank you and nice to see you again. And thank you for serving Puspa during the pandemic. With regard to your question about monitoring and evaluation, I think we need to shift our thinking into understanding what is monitoring and evaluation. It's not just going to the location at the end of the project or while the project is ongoing, you are there and looking. Monitoring evaluation is a very detailed and precision work where you set a target, you set a way to achieve that target, and then in the end you monitor whether the approach was correct and the target was made. Why we need to do it like that? Because if not, then we wouldn't know whether a positive impact was actually generated by a certain intervention or a certain program. For example, if you are familiar with Puspa, then you know that we engage external researcher who is doing monitoring and evaluation to see the quantitative impact, but also the qualitative impact, because sometimes quality does not improve immediately in 6 months, let's say. Quality improve over time and it needs to be monitored, but there is a progress and there is a story to tell, then you have to do it. I think that's the monitoring and evaluation element. It's one thing I know for sure, it is expensive to be done, especially in this current budget cut, where it's very difficult for provincial government or a region government, kabupaten or kota, to be able to take on that budget element. But I would encourage that is still done, because there are ways to do simple monitoring evaluation method where it does not have to be a full-blown impact evaluation, and you can still do have some solid numbers in the end to see whether you are achieving the target or not. And of course, I think it's really very important to be fair. If you are doing something and then you do it, you design it, you do it, and then you claim that you are successful, that is not fair. So there needs to be an external valuation or evaluation by an external party to really understand whether this policy remains to be kept, or it should be changed, or it should be totally deleted from the policy list. I think that's very, very, very important. And it doesn't need to be expensive, but it requires planning from the very beginning of our intervention or our program.
Well, thank you, Dr. Dia. So for Ibu Paramita, is it clear enough for you, Ibu?
Enough for me. Thank you.
Thank you, Ibu Paramita Boni. Next to the second question. Yes, we have Pak Azwar here. Pak Azwar, the screen is yours now. You may deliver your question.
Okay, thank you, Miss Lina. Miss Lina, can you hear my voice?
Yes, it's clear, Pak Azwar.
Okay, thank you, Miss Lina. Thank you, Ibu Dia. I am very happy to meet you today after getting to know GISD for some time and collaborating with them several times to solve stunting problems at several puskesmas in Depok. Bu Dia, my question is, after several years of GISD serving the nation, what is your view on community health in the future, considering that the current government is focusing on curative care? Thank you, Bu Dia.
Thank you for the question. Yes, I think everything begins in community. The communities have a wealth of knowledge of what people need, what people face daily, and I think it's about time that there is transformation in the way government think about communities. It's not just to receive, but also to give voice, but also to design and to create together with government the policy that they need, the regulation that they think they would like to see, and right now with what's going on in the government, I think it's becoming more important to hear the voice of patients or patient groups or patient advocacy groups or public in general, because there needs to be some change if the number of, let's say, adult smokers keep on increasing. Then there needs to be some change how to cut the behavior and change it for the better. And who else to ask but the community? So that's I think where I stand on things for community health.
Thank you, Ibu Dia. So, Pak Azwar, is it clear for you? Okay, I think there's a connection problem. Thank you once again, Ibu Dia Saminarsi, for your insightful presentation and for answering all the questions. We truly appreciate your time and valuable contribution to this session. Now, before we close this session, we would like to take a group photo together with our distinguished speaker, Ibu Dia. And dear all participants, please turn on your camera because I would like to take the moment. Well, yes, let's take the photo together. I will count on. Ready? All right. 3, 2, 1, and smile. Once again. Okay. 3, 2, 1, and smile. All right. Thank you, everyone. Thank you, Ibu Dr. Dia Saminarsi. Once
Thank you.
again, please warm applause for Ibu Dr. Dia Saminarsi. Thank you, Ibu. You may turn off your camera if you have the other activities. All right, dear participants, as we come to the end of this inspiring session of the second International Conference of Sekolah Tinggi Ilmu Kesehatan Rumah Sakit Husada, let us take a moment to reflect on the remarkable insights shared by all our distinguished speakers in day 1 and day 2. Thank you for Ibu Yulisna Mutiasari, SSDFT, MSc, GNR Stud PhD. Thank you for Ibu Yayu Mukarohma Esos MKM. And then, yes, next for Miss Kwang Kyo Wong Cherian, PhD, MS and RN. And for day 2 speakers, Dr. Nur Azliana Azizan and Prof. Michael Joseph Asdino, PhD. We also thank you for Ibu Dr. Eni Juliani MCAT. And the last but not the least, Ibu Dr. Dia S. Seminarsi. Their presentations have broadened our perspective, deepened our understanding, and remind us the crucial role of the health professionals and researchers play in shaping a better and healthier society. Through today's discussion, we have seen how innovation, collaboration, and compassion continue to drive transformation in healthcare, not only in clinical practice, but also in education, research, and community service. On behalf of the organizing committee, I would like to extend our deepest appreciation to all speakers for their valuable contributions and to all the participants of your attention, engagement, and thoughtful questions. May the knowledge we gain today in day 1 and 2 continue to inspire us to move forward, to create meaningful change, to strengthen our commitment to global health in the era of Society 5.0. Thank you very much, and let us look forward with optimism and collaboration as we continue the journey toward a healthier future of all. Okay, thank you. This is from me, from moderator. I will give the next session for the Master of Ceremony, Fitri Adela. Thank you.
Okay, thank you so much, Miss Lina. Wow, yeah, it's such an invaluable insight from our keynote speakers today. Your knowledge and commitment have broadened our perspective and reminded us that essential role that technology plays in infecting healthcare practice and research, especially in advanced education. And also, thank you to all participants for your active engagement, because a conference is not solely about gaining knowledge, but also about fostering collaboration and relationships. So yeah, may this conference serve as a starting point for continued dialogue and partnership beyond this session. Okay, ladies and gentlemen, that concludes our morning session. Thank you very much to all our speakers and participants for your active engagement, and we will now take a lunch break, and the program will resume at 1 p.m. with the oral presentation session. Please note that only participants involved in the oral presentation sessions are required to return after lunch. For the rest of our attendees, we truly appreciate your participation this morning, and we hope you enjoyed today's session. Enjoy your lunch and have a pleasant break. Thank you.
And maybe I hope can collaborate with the people and in this event. So I think that's all from me for the thank you so much. Yeah. One more time, I say thank you so much for the best speaker in the presentation and oral presentation. Thank you.
Okay, thank you so much, Mr. Nohan, and once again, congratulations. Next, we will continue to Mr. Indra Gilang Pamungkas from Polytechnic Negeri Subang. Please, the screen is yours.
Thank you so much for the comedy. I don't know, is it clear or not? My voice there, because is it cloudy outside? Is
Yes,
it clear?
it's so clear, Mr.
Okay. First, thank you so much for the opportunity for me for the best oral presentation. I think all the presentation is also the best, and I'm so happy to be here. I'm so delighted to be here, and to be fair, honest, this conference is, I think, like a place for us to know each other, so we can collaborate in other opportunity. Thank you so much.
Okay, thank you so much, Mr. Indra, and congratulations for being the best oral speakers. Okay, next we will continue for one of our best speakers too, Ivan Gezumi Banate from Angeles University Foundation. The time is yours.
Hello, thank you so much for the opportunity of being able to present our study. It's something that was very well organized, and I very much so appreciate the timely responses with regards to the questions that I had with the conference. Thank you so much for the opportunity.
Okay, thank you so much, Mr. Ivan. Next, we would like to announce the best participants for the conference for this 2 days conference. The first is Rifki Ardiansa from Prodi S1 Keperawatan, and then Sabrina from physiotherapy, bachelor degree, and then Gali from physiotherapy, and then there is Reza from health administration, and Catherine Salim, Mr. Yarvin Yari, Miss Elin Arta Carlina, Mr. Christophus Marcelinus, and Miss Khalida Zia. Congratulations to all the best participants of the conference. And to all the best oral presenters and the best participants, you can contact the committee to claim your reward. Thank you. And we also will have to take a photo for a moment. So please open your cameras and give us your biggest and warmest smile. Okay, so I will lead the photo session. Okay, 1, 2, and 3. Okay, once again, 1, 2, and 3. Okay, thank you so much to all. Thank you so much to all the participants, our presenters, and also once again, congratulations to all of our best speaker and our sincere appreciation to all presenters and participants for your valuable contribution throughout this conference. Over the past 2 days, we have explored a wide range of discussion under the theme of global health issues for healthcare transformation in society. Through the exchange of ideas, innovative research, and meaningful dialogue, we have strengthened our collective understanding of the challenges and opportunities in today's global health landscape. On behalf of the organizing committee, I would like to extend our deepest gratitude all participants for your active engagement and dedication. Your presence and insight have been instrumental in making this event a success. We would like also to acknowledge the hard work of everyone behind the scenes, the committees, volunteers, and also the technical teams whose effort ensured the smooth running of this conference. Especially to the chairperson of Sekolah Tinggi Ilmu Kesehatan Rumah Sakit Husada, Bu Elinia, Sarjana Ekonomi, Magister Manajemen, the head of organizing committee of the second international conference, Nurse Rizka Wahyuni, Magister Keperawatan, to all the vice chairpersons, 1, 2, and 3, and all the heads of the study program, Nurse Nia Rosliani, Magister Keperawatan, Spesialis Keperawatan Medikal Bedah, Nurse Veronica Yeni, Magister Keperawatan, Spesialis Keperawatan Maternitas, Nurse Jehan Puspasari, Magister Keperawatan, and Nurse Sarah Geltri Harahap, Magister Kesehatan Masyarakat. As we officially close the second Sekolah Tinggi Ilmu Kesehatan Rumah Sakit Husada International Conference, let us continue to collaborate, innovate, and strive for excellence in healthcare, both locally and globally. Thank you once again for your participation and commitment. We wish you continued success in your professional endeavors. This concludes our conference. Thank you and have a wonderful day.
Again. Hah? MC keren, moderator keren. Proud of you. Sama lagi Zoom berdua.
Oke, terima kasih semuanya, sukses ya. Izin pamit. Dah. Aduh.